petition. I'm not trying to overwhelm you. I just want to put this term, idiopathic pulmonary fibrosis, in good perspective before we talk about it. So that's a tough background with lots of medical terms to begin, but I hope people that have been diagnosed with pulmonary fibrosis, it just makes you think a little bit about where in the lung the problem is, and that there are other things that are similar to it, and that and knowing that the diagnosis can be tricky times. Is it okay if I do questions at the end?
I just want to do something real quick.
Yes.
Go back to the last screen. That word down there, I want you to just pronounce that for me real quick.
Lymphangiomyomatosis.
That's good enough.
Okay.
All right.
We call it LAM. That makes life easier.
Okay.
L-A-M.
Okay.
So what symptoms do people with idiopathic pulmonary fibrosis have? And some of these will ring true. Shortness of breath that can develop over months. A cough that can progress over months. Clubbing of the fingernails. What that means is that the fingernails develop a slope. And if you put them together, like the two index fingers, that diamond that's between the fingernails, it disappears. And then the development of crackles or rails at the bottom of the chest. But there's a problem with this list of symptoms and signs. The problem is that some people in this room that have been told they have COPD or emphysema say, hey, some of those things look familiar. People that have pulmonary hypertension may say, you know, I have some of those symptoms. So these are not specific symptoms. In other words, there is a characteristic presentation, but it's not specific for idiopathic pulmonary fibrosis. And a lot of the lung conditions can have really overlapping symptoms. So this is tough. I know this is something that everyone who has pulmonary fibrosis has thought about and really wants to know. And I've sort of wrestled with what to put in a presentation about what is the prognosis for pulmonary fibrosis. And I think that I'll tell everyone in this room what I often will tell people when I meet them for the first time. The idea of saying, this is the diagnosis and you have blank years to live, I never feel like I understand things well enough. I've already told you this is a condition that we start off with saying it's idiopathic, and that there's real value in meeting people and seeing how they're progressing over time before offering a prognosis. And part of the reason is that there's clear evidence, and those of you all that know the doctors in Northern Virginia, they've taken an interest in this and trying to find out, well, are there people with this condition that have a more favorable prognosis? Are there different groups? And it's clear that there are, and that it takes some time to sort of understand and see how that's going. And it's funny, you develop these elaborate medical research studies, and then it sometimes comes down to, well, people that seem to be progressing fast, their prognosis isn't as good as people who seem to be progressing slowly. It doesn't sound like rocket science, but understanding that is helpful. And I think the most important thing is knowing that this, certainly is not a one-size-fits-all condition. So there is a typical progression of shortness of breath over years, and in the late stages, often people require high flows of supplemental oxygen to wear. I don't have anything in this talk about oxygen and supplemental oxygen and the tricks with it. Everything's open game at the end. So I already went through the last statement that I have there. So how is a diagnosis made of idiopathic pulmonary fibrosis? I already told you history and exam, some of the typical symptoms that can tip a person, their family member, a doctor off to the idea that maybe they have pulmonary fibrosis. Oftentimes the next test may be a chest x-ray because it's easy to do and it's simple to do, and it can be followed easily over time. But a chest x-ray doesn't quite have the detail to be diagnostic of pulmonary fibrosis and to give you enough of an idea of the patterns to really tell what's going on. So oftentimes, a CT scan is done as the next step. And the CT scan, I'll show you some pictures in a minute and what we're looking at. But the CT scan at times can be diagnostic. But it has to be the right situation. It has to be something where the doctor says, you know, this whole situation really fits. The main thing I was thinking of was idiopathic pulmonary fibrosis, and the main thing on the CT scan is that it looks like pulmonary fibrosis. And you put those two together, and it makes the diagnosis with that alone. But oftentimes, as many of you all probably know, the picture is not that straightforward, and there's doubt whether it's in the CT scan or in the clinical history of what the right diagnosis is. Pulmonary function tests are very important. They aren't going to diagnose the condition, but they're helpful. How many people in this room have had pulmonary function tests? Probably very high, many of you. You'll know that the value of those tests is one that different types of disease, like interstitial lung disease, may look very different from COPD on the breathing test. So it can be helpful to differentiate, but there can be a lot of value of following those numbers over time. It's not that you can follow any one thing and truly know how things are responding over time, but it can be a good clue at times as to, okay, how are things doing on these tests over time? And then blood tests are often done at the beginning, mostly to look for other things. Is there any evidence of an autoimmune problem, rheumatoid arthritis, scleroderma, anything else that could be going on that could be associated with pulmonary fibrosis, dermatomyositis, anything else? So these are pictures from different CT scans that fit with pulmonary fibrosis, and I'll try to show with each picture what's going on. So we'll start out up here, and on all these images they're the same. On this top row where you have a person's chest up here, whoops, their back over here, and then right and left are switched up, so right lung and left lung. In this left-hand picture, you have sort of an area that looks very normal to me around here. It's a nice grayish color in the middle, all throughout here. And these white lines are blood vessels going throughout. At the outer edge is the pulmonary fibrosis. So you can see that on both sides. So the clues on this CT scan is that it's what we call bilateral, meaning that it involves both sides. That it's near the edges or the periphery, that it's also more at the bases than at the anterior area up here. The last thing that's very subtle on this picture, there's an airway that won't project at the back, but it's larger than the other airways, and the airways with fibrosis get pooled. Has anyone heard the term bronchiectasis? At all? Okay, so bronchiectasis can come about from many things. Pulmonary fibrosis is one, where the scarring process can pull the airways and create traction. So it's different from bronchiectasis from an infection. This is bronchiectasis associated with fibrosis. But you can see all these things here. So a radiologist might say, this CT scan shows a fibrotic process involving the periphery and the bases and associated with traction bronchiectasis consistent with pulmonary fibrosis. And then it's up to the pulmonologist to take that information with the history and exam and to see, okay, does this fit or not? I'll skip a couple of these, but just move down to show you one that may be easier to orient with. So on these bottom images, you can see, we'll go with this bottom left one. Left and right are mixed up. So here's an outline of the right lung, here's an outline of the left lung. And you have this area at the bottom that looks fibrotic. It's sort of white compared with the grayish tone up here. And there are little black holes throughout. Has anyone ever heard the term honeycombing when a CT scan was mentioned? A few people have. This is a term that radiologists use, and it goes with fibrosis often. So this is what the CT scans often look like with pulmonary fibrosis. You can see that there's a lot of detail on these pictures. So that's why over the last 10 years, that has been some progress with the diagnosis. Sometimes the CT scan in itself is good enough. This question comes up very often, and it's not surprisingly individualized. There's no right answer to this in terms of a group setting. What should you do? But the question that comes up is, should a surgical lung biopsy be performed? The reason that there's a question that they don't say, well, of course you want to take out some tissue and look at it under a microscope, because that's going to give you the best diagnosis you can. You're never going to get a better view than to really look at it under the microscope. But this is old now. The surgeons now are so much better, and they do minimally invasive procedures, so this has gone down. But the mortality traditionally has been very high with idiopathic pulmonary fibrosis, and you think, okay, a diagnostic test with a significant mortality associated with it, you better really need that diagnostic test to make the benefit outweigh the risk. So how is it going to change management? What is it going to do? So this number is no longer accurate, but it's still one that's in the mind of pulmonologists that have been practicing for a while. So for a long time, the idea has been, can we come up with other ways to make the diagnosis without that? And oftentimes, the CT scan alone is good enough. There are many cases where a person will get referred for the open lung biopsy when it's not clear, and important decisions hang in the balance, like, is this idiopathic pulmonary fibrosis? Or is there anything else on that list that would respond to steroids that this might be? And that can be an important enough question that this biopsy is indicated. Another reason that you individualize this is, you all can imagine the risk varies a lot. If someone's in the hospital and they've gone into respiratory failure and they're on a ventilator, their risk is going to be very high with that procedure. But if someone is in the outpatient setting and breathing fairly comfortably, their risk is going to be very low from that procedure. So that's why it's another reason why it's so individualized. So there is a growing reliance on the CT scans, the history, and the pulmonary function test. Most of the clinical studies at this time do not require an open lung biopsy for inclusion, but it's very common to say, well, if someone has had an open lung biopsy, then send the slides to the central reviewer for that study, and they'll look at them as part of the entry to the study. Transplant centers do not necessarily require open lung biopsy for diagnosis. 15 years ago they did. If you had pulmonary fibrosis, then you needed to have a lung biopsy to be considered for transplant. It's no longer the case. But like I said, this open lung biopsy or surgical lung biopsy is still considered very valuable in assessing someone when the diagnosis is in question at all. Is there a blood test for IPF? So I heard rumors this question is going to come up, so I was trying to address it and figure this out.